Good afternoon, everybody. Now we are going to start the clinical section, and that section will be started by a presentation from surgical side. So there will be 3 cases. 2 will be presented by Professor Umomien from Magwe, University of Medicine, and 1 by Dr. Winbu from North Oklahoma Teaching Hospital. So without wasting time, may I invite Professor Umomien to start his first case.
Okay, thank you, Professor Siai Utu, for your kind introduction. So actually, we have 2 cases. Okay, can you see the slide?
Yes, we can see it. You can see it.
All right.
Okay, good.
This is a very interesting case from University of Medicine, Magwe.
Hello?
Oh,
Hello?
oh, sorry.
Huh?
This is a very interesting case from University of Medicine,
we,
Magwe.
we do 10%
It is a 10-year-old boy presenting with repeated attack of hematemesis, and he was admitted to our surgical ward of the Magwe Regional Hospital. He had hematemesis and about 100 ml. Regarding the past history, he has similar attacks since the age of 1.5 years, and he had a frequent hospitalization about 10 times within 10-year duration with hematemesis and melena at Magwe Regional Hospital. Actually, it was to the pediatric wards. So he was treated as cirrhosis of liver with portal hypertension. And at the age of 5 years, he was under care of pediatrician in the past, and they refer him to the Yangon General Hospital GI unit. And the child underwent first endoscopy at the age of 5 years, and they found the grade 4 esophageal varices, and they did the EVA. I'm not sure about the procedure, but they look like under general anesthesia. And he underwent second time. He had a repeated attack about 5 times within 5 times or 10 times admission. So he underwent second endoscopy and EVA at the Yangon General Hospital GI unit. And he had a third time recheck. And after 2 months later, he came back with a repeated attack of variceal bleeding, and he was admitted to our general surgical ward. So he, on examination, he had a no stigmata of chronic liver insufficiency. He has no jaundice, no clubbing, no ascites, no peripheral edema, except the huge splenomegaly. His hemogram show he was negative for hepatitis screening, hepatitis viruses, and liver function were within the normal limit. Actually, he underwent ultrasonography in 2014, and it was in Yangon General Hospital. It showed the fairly coarse echo in the liver, and portal vein was tortuous dilated vessels in the prehepatic, perihepatic, and splenic region. Spleen was moderately enlarged, and the radiologist's opinion from Yangon General Hospital in 2004 was he diagnosed as a chronic hepatitis with portal hypertension. And we repeat the ultrasonography in 2016 at our hospital. So actually, they reported as a normal liver with splenomegaly with portal hypertension. And this is a comparison between the 2 ultrasound from Yangon General Hospital and our hospital. And this is a CT abdomen. It was done in 2011 at Asia Rai Hospital, but it was a gastroenterologist direction. Actually, radiologists reported, Professor Siai Utenlue, he reported as hepatic fibrosis, huge splenomegaly, and portal hypertension. So this is, I'm not sure about you. Can you see the point out? That's the portal vein is very much dilated. There's a huge splenomegaly on the right hand side. And Professor Siai Utenlue reported as portal hypertension probably secondary to hepatic fibrosis. Liver biopsy may be helpful for confirmation. And we repeat the CT abdomen in 2016 in our hospital. Actually, our imaging quality is not as good as Yangon General Hospital, but it showed a huge splenomegaly. And portal vein was very much dilated. And there are many pooling of the dye in the highland, the liver highland. And our radiologist reported as a splenomegaly with portal hypertension. So they didn't mention about the state of the liver. And there's no diagnosed as a cirrhosis. And clinically, we don't have a stigmata of cirrhosis. So what is the cause of this repeated hematemesis? How are we going to treat? So obviously here the hematemesis and melena due to esophageal varices because he had 2 times of EVA by gastroenterologist from Yangon General Hospital. So what is the cause of esophageal varices? No doubt it is due to portal hypertension. Okay, so actually we review the literature. So there are many causes: pre-hepatic, intrahepatic, post-hepatic. Actually, majority, almost all cases are caused by the cirrhosis. But pre-hepatic causes for the vein is rare, and post-hepatic causes are not reported in our country. And there's a inflow hypertension, hypersplenism, hepatoarterial venous fistula. So this is a portal vein anatomy. They mentioned about the extra non-cirrhotic causes of portal hypertension like pre-hepatic portal vein thrombosis, splenic vein thrombosis, and post-hepatic causes like Budd-Chiari syndrome, constrictive pericarditis, etc. So possible causes in this case, positive vein thrombosis, podocyvanoma, cirrhosis, schistosomiasis, and Budd-Chiari syndrome. But reviewing back his history, there was no history of umbilical sepsis, which could cause portal vein thrombosis, and no stigmata of chronic hepatic insufficiency, and liver function were normal, and he was negative for viral markers. So we are thinking whether he might have a Budd-Chiari syndrome, but actually his clinical picture didn't look like Budd-Chiari syndrome. Budd-Chiari syndrome is a hepatic venous outflow obstruction, either due to thrombosis or tumor or obstructed lesions in the inferior vena cava or the right heart. But he has no history of, no symptoms suggestive of Budd-Chiari syndrome. This is a Budd-Chiari syndrome and causes. And these are clinical features. So he doesn't have a side D. And actually, I reviewed the CT scan with Professor Donunu A from Magui Regional Hospital. So she said it could be a case of for the cavernous formation of the portal vein. She said she had an experience in Singapore, and she reported 1 case in Singapore. So it's quite likely, sir. Sorry, actually, this is a podocyvanoma or cavernous formation of the portal vein, first reported by Belfort and Stewart, and the term cavanoma was used later by another surgeon. And this is a cavernous formation. The etiology is not exactly known, but they suggested that the thrombosis of the portal vein leading to cavernous collaterals, which later manifested as a podocyvanoma. Actually, this is a picture from the China. So the quality is very good. So there's a lot of malformation, cavernous venous formation around portal vein. So actually, we corrected anemia. Patient underwent vaccine or elective surgery. Actually, we decided not to repeat the EVA. So we are general surgeons, so we decided this should be, patient should have a revascularization procedure. So actually, this is a operative finding. His liver was normal. One thing I regret was I didn't do the biopsy because liver was normal. He has been with the H&M and portal hypertension for many years. So a liver should be cirrhotic. So I didn't do biopsy. Liver was completely normal, glistening, normal color. And there was huge splenomegaly. And there was a lot of tortuous dilated veins around the liver highland. So I did the splenectomy. Extensive devascularization procedure. I'm sorry for poor quality. At that time, the camera were not very good. So this is the esophagus and this is a gastroesophageal junction, and this is the stomach side. So I did extensive devascularization, cut and clamp until the serosa, actual muscular layer of the esophagus is reached. I did the splenotomy first, followed by devascularization of the gastroesophageal junction. But I didn't do the transaction procedures. So this is the gallbladder. This is a completely normal looking liver, and this is a tortuous dilated vein. It looks like about the size of my thumb, so it's quite big, big. So and then 4 or 5 vessels around the highland, liver highland, going to the highland. Actually, after spleen, here the thrombocytopenia after splenotomy, platelet count went back to normal. Here the uneventful recovery, and this is a postoperative scars, midline scar, and this is a postoperative finding. And actually, I forgot about him for 4 years, and after that, there's because of this meeting, actually I got him by phone, and he underwent. He was at the time of operation, he was 10 years old, but he's now 15 years old. So actually, we repeat the OGDS. So yeah, actually.
Hello, meeting low, we don't know what you're saying.
This is Abaji endoscopy. So esophagus until the 35 centimeter was normal, but there's a small area regarding VC here. Yes, only in one column, maybe about, I might say grade 2 esophageal varices, otherwise normal. And sorry, actually I did the I inspected the fundus of the stomach. There was no gastric varices, and this is a duplex scan performed by Professor Donunu A. It showed dilated veins around the liver highland, and liver architecture showed bright echoes, but otherwise normal, not amounting to cirrhosis. There was no obstruction on the hepatic vein, which could be occluded by Budd-Chiari syndrome. So no evidence of hepatic vein except the dilated. And this is a red color and blue color. They show the direction of the blood flow. So this is a finding. So it's only dilated veins around the highland. It's a key point. She reported as a chronic hepatitis, but clinically there's no evidence of chronic hepatitis. And given us malformation of the portal vein. Actually, I tried to find many years for the diagnosis, but I discussed the X-rays with the heart, and she pointed out this is a cavernous malformation. It's quite likely. So it's a brief literature review. Actually, because this is a short clinical session, so I don't want to go into detail. But there are many treatments. So we might have resuscitation first, followed by finding the cause, underlying cause, including cirrhosis, and then we have to treat. If it is due to cirrhosis, the easiest way is repeated endoscopic variceal ligation. If it is failed, we can treat with the devascularization procedures, autocavation shunts, tips, and finally liver transplant. Actually, these are very sophisticated. So the operation we can perform by general surgeon is the devascularization procedure. In 1985, Professor Sugiura from Japan, he reported the extensive devascularization from thoracic cavity as well as abdominal cavity, splenectomy, and esophageal transition. We had a high success rate, but high mortality, and this is difficult to repeat. So nowadays, general surgeon do the modified Sugiura procedure. That is the only abdominal approach, and transition is only done by the staplers. So Professor Wu Anwen, he was a pioneer in Myanmar, and he did modified Sugiura procedure for his doctoral thesis. Actually, it's quite difficult to reproduce. So that's another procedure called the modified HACCP procedure. Actually, HACCP started his operation in 1967, so many years earlier than the Sugiura procedure, but it was not popular, not very popular in the Western country. So he reported his original operation included the extensive devascularization procedure, bigotomy, and splenectomy. There are many modifications. So what we did here is splenectomy and extensive devascularization. So I think one doctoral thesis was reported. Dr. Myomitan from University of Medicine too, and Professor Udan Luen from liver unit, he performed some procedures. So I learned this procedure from Professor Uto Uhanwe, and I perform on my own. But actually, we have no reported case, but in one study from China, they study more than hundreds of cases, more than 100 of patients under 10 years. They presented, these are the clinical characteristics. These are the site of obstructions on the right-hand side. And there are many treatments for these patients: conservative endoscopic therapy, emergency sclerotherapy, prophylactic endoscopic approach, albumin, surgical procedure, splenectomy plus vascular disconnection, liver transplant, and splenorenal shunt. So the take-home message is portal carcinoma is a rare cause of portal hypertension. It starts with portal vein thrombosis, followed by reconalization and collateral formation. Referral to specialist center is necessary. Endoscopic variceal ligation and devascularization procedures are effective. Okay, thank you so much for your attention.
Thank you, Professor Umumia, for your very interesting case. Well, I would like to ask one question to Siamu, that why didn't you choose to do some form of shunt procedure to reduce the portal hypertension? Because this is definitely a case of portal hypertension due to portal vein thrombosis or portal vein occlusion. Somehow the original cause, I don't know. But if you can do a shunt, the variceal problem will be solved, I think. Because we have done one case, a 19-year-old girl referred to me by Professor Tan Tan a physician, general physician. So we decided to do proximal linorenal shunt because distal linorenal shunt is very difficult and I haven't done it. So we decided to do proximal linorenal shunt because we dare not approach the portal vein area to do a portal cable shunt because this is a messy area with a lot of dilated veins. So we try to approach the renal vein and splenic vein, and then we connect it. And then after that, the problem was solved. So what is your opinion, Siamu?
Okay, good. Thank you so much, for your kind advice. But first of all, I'm not the expert in portal cable shunt. I only did one cases, and actually this shunt has a high modality. So there, generally speaking, there are two shunts. The main portal cable shunt, which has a high modality, and the selective shunt at the devascularization area of the stomach, which is a linorenal, different forms of linorenal. So linorenal shunts has a shunt occlusion rate after 3 to 5 years, and they have a less chance of encephalopathy. But central shunts, they can have a post-operative encephalopathy, and quality of shunt may not be as good as the other procedure. So I decided that this is the first procedure, and it lasted for 4 years. And after that, if this I might have to refer either you or specialist center for the cable shunt. So this is my thinking. So let's start procedure. And the shunt has a high modality, high modality and high encephalopathy chance rate. So I dare not to do it. Thank you, CIA.
Usually the liver function in these cases are normal. So if you do not a central shunt, if it's a peripheral shunt, then that might have solve the problem for longer years.
Okay,
So
thank
now
you so much.
the floor is open for discussion as well. Any questions from the audience or any discussion or comment from the audience? It's invited. Welcome. So there is one question. Is there any role of medicine like propranolol in patients who cannot undergo surgery? From Sia Unyon Teng.
Oh yeah,
Oh,
it's a very difficult question. Yeah. Actually, we surgeon don't believe the propranolol. There are but many trials which favor the propranolol. But I think one paper stated that in combined with the I think endoscopic vesical ligation plus propranolol is effective. But propranolol alone trials are going on, but I don't know the result. I don't know the result. But what happened is if the patient stop completely, there's a rebound phenomenon and they started to bleed. So they need to take lifelong procedures. Lifelong. I think TIPS is a lesser procedure. Transjugular intrahepatic photosystemation is a minimally invasive procedure, less morbidity and mortality. But I think shunt occlusion rate is the same, but after 2 or 3 years. Propranolol is effective to some extent, but I cannot say propranolol alone is effective. But the trials are going on, so they might be beneficial in the future.
Yeah, the only thing again, if the patient cannot undergo surgery, so he's suggesting propranolol.
Yeah, definitely, yeah, definitely, yeah.
Okay, any questions from the audience or any discussion from the audience? If not, we are going to proceed with next case. Oh, question answer. Okay. Okay, if there is no more comments or questions, so we are going to proceed with new case, next case. That will be presented also by Professor Umomi from Macquarie as well. Kumu, please proceed with next case.
Oh, okay, yeah. Okay, can you see the slides?
Not yet. It's, yes, now. Kumu, you have two weapons.
Oh, okay, oh, okay. So, this case, it was about 4 years ago. 4 years ago, so 39-year-old male with psychiatric problem, who stabbed himself by the kitchen knife several times to the abdomen as well as the chest. And he was admitted first to Mainland Hospital and then referred to our hospital. He arrived at night, early at night, about 7 p.m. He has a history of chronic alcoholics and alcoholic-related psychosis. Examination revealed he was hemodynamically stable and his oxygen saturation was 95% with air. And there's a reduced air entry on the left side. And there's a weapon inside you in the center of the lower chest, which was moving with each heartbeat. So this is a situation, sorry. I took the video, but so this is only the picture. The picture, so his hemoglobin was 8.1. We cross-matched him, and he also was found to have a hepatitis B surface antigen positive. We did the chest X-ray, and we reserved 5 units of blood. We prepared for the emergency situation. This is an X-ray. It was not very informative. This is a anthroposia posterior view, which revealed the haziness in the left side, and this is the lateral view. So the knife was piercing until just before the vertebra. So it could pierce any mediastinal structures. Actually, we have no experience, no cardiothoracic surgeon, so I consulted with Professor Winjo. It was 4 years ago by telephone, and I sent the X-ray picture, plain X-ray picture with a Viva. So actually it was a telecommunication or teleconsultation, but it was not popular at that time. So actually, so we discussed with the CCIE discussed with the Japanese professor this morning. So I actually, so what he said was, Professor Winjo သူဘာပြောလဲဆိုတော့သူကတေသွားရင်အရေးမယ်ဘာလို့ဆို specialist center မန္တလေးကအနီးဆုံးပေါ့ကျွန်တော်မန္တလေးက6 hour drive အနီးဆုံးဆိုဟိုတေအရေးမယ်ပြီးသွားရင်ရှင်အမြတ်ဆိုကျွန်တော်ခုတည်းနားမလဲအဲ့စကားကိုဒီမနေ့မှကျွန်တော်နည်းနည်းစဉ်းစားမိတေရင်အရင်ဆိုတာကျွန်တော်နားမလဲတေမှတော့ရှုံးပြီပေါ့ဒါပေမဲ့သူကငကိုတွေကဒါတေလောက်တဲ့ယောဂပေါ့တေလောက်တဲ့ယောဂပေါ့နောက်တစ်ခုကအဲ့ကြသူက thoracotomy ဘယ်လို perform လုပ်မယ်အဲ့ဒါကိုသူပြောတယ်နော်တကယ်လို့ ventricle ပေါက်မယ်atrium ပေါက်မယ်ဆိုသူဘယ်လိုချုပ်ရမလဲသူက pericardial patch နဲ့အဲ့ဆူချတဲ့ material ပါတယ်သူချုပ်နီးတယ်ကျွန်တော်ဒီ cut through ဖြစ်မှာဆိုအဲ့ဒါသူပြောလိုက်တယ်ဆိုတော့ကျွန်တော်ရဲ့ background ပေါ့နော်ကျွန်တော် background limitation ကလည်းရှိတယ်ကျွန်တော် background vascular surgery မှာ experience ရှိတယ်အများကြီးရှိပါဘူးအင်္ဂလန်မှာတော့ကျွန်တော် carotid aneurysm လုပ်နိုင်တယ် under supervision ပေါ့နော် aortic aneurysm repair ဆိုရင်ဟိုတစ်ဝက်လောက်လုပ်နိုင်တယ်ဘာလို့ consultant နဲ့ကျွန်တော်တွဲလုပ်ပြီးတော့အပေါ်သူဆက်တယ်အောက်ကိုဆက်တယ်ဘာ experience နဲ့ရှိတယ် fan port တွေဘာ experience ရှိတယ်ဒါလောက်ပဲ cardiothoracic experience လုံးဝမရှိဘူးပေါ့နော်မေဈေးဘက်ကလည်းလိုသေးတယ်မေဈေးကတော့သူအဲ့တော့သဘောကောင်းတယ် senior consultant မှာအခုတော့ ENT မှာရောက်သွားပါဟိုကကျွန်တော် IM2 ထွက်ပါတယ်ခင်ဗျအဲ့ဒါဆိုတော့သူကလည်းသဘောတူတယ်အဲ့ဒါနဲ့ကျွန်တော် data prepare လုပ်တယ်သူပြီးတော့သူ on table မှာလည်းသင်နိုင်တယ်ဒါတော့ဝင်းကျော်ပြောထားတယ်ဒါကျွန်တော် explain concept တယ်ပေါ့ဒါပေမဲ့သူကောင်းတဲ့ချက်က hemodynamically stable ဒါအောင်လည်းမေဈေးကလက်ခံလိုက်တယ်ကျွန်တော်ဒါဟိုဖြစ်တာ thoracotomy ပေါ့ဒါတော့ဝင်းကျော်ပြောတဲ့အတိုင်း left thoracotomy pedicardiotomy နော် luckily ကတော့သူကတကယ်တော့ heart ကိုမထိဘူးသူရဲ့ active blade ပေါ့ sharp blade ကဟိုအပြင်ဘက်မှာနေတယ်သူ heart ဘက်မှာကျတော့သူက blunt blade အဲ့ဒီမှာနေတယ်အဲ့နဲ့ကျွန်တော်အဲ့ဒါကြီးကိုတေချာ remove လုပ်တယ် heart မှာလည်း injury လုံးဝတိတ်ဆိုးဆိုးဝါးမရှိတော့ ICT ကျူးထည့်တယ် pericardial drain ထည့်တယ်နောက်ပြီးတော့မှဟိုဖြစ်သွားတယ်နောက်တော့ patient survive ပေါ့ဆိုတော့ massive hemothorax ရှိတယ် massive hemopericardia massive တော့မဟုတ်ဘူးကျွန်တော် hemopericardia ရှိပါတယ်အဲ့ဒါနဲ့နောက်သူဘိုက်မှာလည်း step wound နဲ့ရှိတယ်အဲ့ဒါတော့ကျွန်တော် cirrhosis တဲပဲကျွန်တော်ဟို general surgeon ဟိုကျွန်တော်ဟို assistant တယောက်က repair လုပ်လိုက်ပါဒါကျွန်တော် video ပါဟိုဆရာကြီးတို့မြင်ရလားမဟုတ်တယ်
မြင်ရတယ်ကိုမိုး
very good so the knife was moving with the kitchen knife it was moving with each heartbeat so we prepare for surgery so we clean the left thorax and we did the left anterolateral thoracotomy as directed by Professor Wenjo. So actually the handle was shaking and we have to cut the sternum with the orthopedic instruments. Actually we have no wrist spreader but we use the abdominal barefoot retractor. The thoracic surgeon they recommend Fino sheet to wrist spreader. Well, we don't have so it's not difficult so we use the abdominal retractor as well as simple retractors. So this is there's a gush of blood. So hemothorax, massive hemothorax about 2 liters. So we drain it first. So his saturation improves. This is a hernia retractor. Hernias, it's quite easy. And then I did the pericardiotomy. So this isဒါကြီးလိုက်မလို့ဖို့ကျွန်တော်အကြံပေးပါတယ်ဘာလို့ကျွန်တော်လည်း expert မဟုတ်ဒါလောက်လိုက်ဒါတကယ်ဒါ specialist တွေလုပ်တယ်မှာ cardiothoracic surgeon တွေနေကိုပို့ပြီးတော့ဒါတွေအကုန်လုံးကကျွန်တော်လုပ်တဲ့တယ်လို့ယူဆပါတယ် general surgeon မလုပ်တယ်မှာကျွန်တော် pericardiotomy ပေါ့ကျွန်တော်လည်းဟို peritoneal big လောက်ပွင့်သွားပါတယ်ပွင့်သွားတော့ sun blood ပေါ့ hemopericardium ရှိပါတယ်နော်left ventricle beating heart ပေါ့သူ heart rate ကတော့တော်တော်မြန်တယ်မြန်မာဟိုကျွန်တော်ဒီဘက် knife ကတော့မရောက်သေးဘူးကျွန်တော် knife ကိုအနေထားကိုတေချာစမ်းတယ်နော် pericardial blood တွေကျွန်တော် suck လုပ်ပါတယ်ကျွန်တော်လက်နဲ့အရင်ဆုံးဟိုစမ်းလိုက်တော့သူ့ရဲ့ blade က active blade ကဒီ anterior ဘက်မှာ blunt blade က heart ဘက်မှာဆိုသူ့အတွက်ကံကောင်းတာပြီးတော့ကျွန်တော်လက်ကိုအောက်ကခံပြီးတော့မှကျွန်တော်အပေါ်ကနေကတ်လောက်ထားတယ်ဒါပြီးတော့မှကျွန်တော် knife ကိုဖြည်းဖြည်းဆွဲထုတ်ပါတယ်ကျွန်တော် by manual preparation ဖြစ်တော့အဲ့ချိန်မှာကျွန်တော်ကတကယ်တော့ major ventricle တွေပေါက်ရင်တော့သူကတည်နိုင်တော့ arrest ရတယ်ဒါပေမဲ့ဟိုကျွန်တော်အထဲမှာလည်းမရှိဘူးဖြစ်ခဲ့ရင်တော့ကျွန်တော်ချော့မှာတော်ဝင်ကျော်တော့သူအဲ့ချုပ်ပြီး pericardium patch နဲ့ချုပ်ဖိထားပြီးတော့အဲ့လိုသူအကြံပေးပါတယ် ဒါသူ့ရဲ့ဟပ်အောက်ကကျွန်တော်အောက်ဘက်ကနောက်ဘက်ကဟာတွေဟိုဖြစ်တာပါဒါတော့ left ventricle ပဲ left ventricle ကျွန်တော်နောက်ဘက်မှာနည်းနည်းပါဆန်းတယ်ဟိုဘာမှတော့မရှိပါဘူးရှိသေးတယ်ရှိလဲကျွန်တော်လုတ်တတ်ဖို့တော့မလွယ်ပါအဲ့ဒါဒီ pericardium drain လောက်တတ်တယ်တခြား site လောက်တယ်ကျွန်တော် irrigation with saline pericardium တော့ပြန်ပိတ်လိုက်တယ်ဒါပိတ်သိမပိတ်သိတော့ကျွန်တော်မသိဘူး cardiothoracic surgeon မှာမေးကြည့်ပိတ်လိုက်ရင်တော့အဲ့ထဲကလုံသွား infection ဝင်နိုင်တော့တစ်ဖက်ကလည်းပိတ်လိုက်ရင်တော့ထဲကတန်ဖိုးနိုင်ဖြစ်သွားရင်သူပြန်စုနိုင်သေးတယ် theory ရတာအဲ့ blood ဘယ်ကလာလဲဆိုတော့သူ myocardium တို့ major တော့မဟုတ်ဘူးကျွန်တော် minor vessel တစ်ခု injury ရလို့ဖြစ်နိုင်ပါတယ်Okay. To cut a long story short, hemodynamically stable since early post-operative period. And ICTG was removed on the 6th post-operative day. And post-operative, here's the first and second sound with no added sound. And lung was show the vesicular breath sound. And his abdomen, soft tender, or sound present. And we repeated the echo. We did the echocardiogram for a week later with normal basic echoes. This is a show the ECG. It was completely normal. This is a scar and laparotomy scar. Actually, we sent him to the psychiatrist. We follow up him for a year, so it was okay, and so he was discharged from our clinic. So the lesson we learned from this case is cardiothoracic trauma is one of the common surgical problem. And general surgeons don't have a training for this kind of injury. And telemedicine and telementoring would be an adjunct, but not a substitute in managing this type of trauma. Appointing cardiothoracic surgeon at state divisional hospitals and referring to nearest center would be the best solution. So general motto do no harm. Hippocraticပြောလို့ primer none nor cure primer none down do no harm. အဲ့ကျွန်တော်ခွဲလိုက်လို့လူနာ injury ရမှာမဟုတ်ပါဘူးသူကသူသေပြီးကျွန်တော်ဟိုကြောင့်တော့မသေသေးချင်ဘူးเนาะအဓိကအဲ့ဒါပေါ့ဒါပေမဲ့ဒီ case ကတော့ကျွန်တော်လည်းဟိုမဖြစ်ပါဘူးအမှန်တော့လူနာဟိုဖြစ်လိုက်တော့ဒေါ်ဝင်းကျော်နဲ့ခွဲလိုက်တော့သူ support သူအားပေးတာနဲ့အဲ့ဒါနဲ့ကျွန်တော်လည်းလုပ်လိုက်ဒါပေမဲ့တက်နိုင်တော့ဒါတွေကမလုပ်သင့်ဘူးဒါပေမဲ့ referral center ရှိရင်တော့ကျွန်တော်ဘလို့မှလူနာသေမှာပါအဲ့ဒါကြောင့်ကျွန်တော်နောက်ပိုင်းကျွန်တော်နိုင်ငံတိုးတက်လာရင်တော့ cardiothoracic surgeon အနည်းဆုံးဆေးရုံကနေဒီကို airlift နဲ့လာမလားဒါမှကျွန်တော်က helicopter တော့ပါနဲ့ပဲအနည်းဆုံး center ကိုပို့မလား1 hour drive ဟောပေါ့ helicopter တော့တနားရီလောက်ဆိုရောက်မှထင်မှာအနည်းဆုံးလားအဲ့လိုဆိုတော့စိတ်ကူးရပါဒါဆရာကြီးတို့လည်းအကြံပေးပါတယ် Thank you so much for your attention.
Thank you, Kumu. Big congratulations for saving one life. One life. Well, ဒုမမရှိတဲ့နေရာမှာကိုမိုးလောက်တာတော့ကျွန်တော်တော့ထောက်ခံပါတယ်ဘာဖြစ်လို့လဲဆိုတော့ဟလာ SAS တရားပြောတယ် British SAS တရားပြောတယ် Who dares win နဲ့မော်စီတုံးကပြောတယ်တိုက်ရဲတဲ့လူတွေအောင်ဝဲရလက်တကားမှာပဲရှိတယ်ဒါကမထားရင်လည်းသူဒုက္ခရောက်မှာပဲဘယ်မှလည်းပို့လို့မရဘူး so you have saved a life ဆိုတော့ congratulations ပါကိုမိုးဒါတွေကတကယ်တော့မသိဘဲနဲ့တချို့နယ်တွေမှာတချို့လာလူတွေ save လုပ်ခဲ့တဲ့ဟာတွေအများကြီးရှိမယ်ဗမာပြည်မှာ record တွေမရှိလို့ပေါ့အချိန်တော့ဟို years မှာသိမကြခင်နေ့ကဖြစ်သွားတဲ့ကိစ္စမှာလည်းအဲ့လိုပဲပေါ့နော်အဲ့တော့ဒီလိုပဲ they could save ပေါ့အဲ့လိုပဲဟိုးအရင်ကလည်းဆရာကြီးဦးတော်ကဒါမျိုးတွေဆရာဦးတော်မန်တို့ကဒါမျိုးတွေကိုသူလုပ်ပြီးတော့ save လုပ်ခဲ့မှုတာတွေအများကြီးရှိတယ်ပေါ့ကျွန်တော်တို့ရှိမှာ record တွေမရှိဘူးအခုတော့ communication တွေကလည်းပိုကောင်းလာတယ်ဆိုတော့ကိုမိုးရဲ့ final remarks တွေကိုလည်းကျွန်တော်ထောက်ခံပါတယ်ခုနလိုအခု telemedicine နဲ့ telementoring ပေါ့ဟလာခုဆိုရင် telephone နဲ့အချိန်ကြီးကျွန်တော်တို့အချင်းချင်းတွေဆက်သွယ်ပြီးတော့တိုင်ပင်လို့ရတယ်ဟလာဆိုတော့ advice မရရင်တော့ encouragement ကတော့ရတာပဲလေဆိုတော့အဲ့တော့any where there are 6 questions I've seen here Tira, congratulations. Is there any role of medicine out there? How many? So, not about she did is this patient still in this world? I am not about your surgical skill and expertise. I am worried about his underlying psychiatric problem. It may be Manchurian syndrome, and he may repeat such self-inflicted injury. That's a comment. Any comments or questions from the audience? So far, also congratulations. So, any more comments or questions from the audience? Well, if there are no more comments from the audience or questions from the audience, I would like to congratulate Xiao Momien, so who has done a daring operation, and we really support his decision. Oh well, there are one from AP Dr. Also Min. The knife was not sterile. What have been done during operation?
Oh, sorry, I have to apologize. I didn't do the antibiotic washout or the betadine washout. I'm not sure the reaction of the betadine, so I just irrigated with the saline, and we gave the systemic antibiotics. Actually, I'm not sure whether we put the topical antibiotic. So actually, the patient was no fever, completely healthy. It had went about 4 years ago. So actually, we didn't follow up for the psychiatric assessment, but we referred to psychiatrist for 6 months. 6 months. We follow up for 6 to 6, I think maybe 7 to 9 months. 9 months. After that, he didn't come back again. Again, so and then ကျွန်တော် antibiotic washout တွေပါတော့မလုပ်ခဲ့ဘူးကျွန်တော် saline နဲ့ပဲအဲ့တော့ကျွန်တော်လည်းမစဉ်းစားမကင်းပြီပေါ့ကျွန်တော် systemic antibiotic ပေးတယ် ATT လည်းနောက်ပိုင်းတော့ထိုးပါတယ်ဟုတ်တယ်
I think the patient is from Macquarie လားကိုမို့
ဟုတ်ကဲ့
ဆိုတော့ဒါဆိုရင်တော့ down ဖြစ်ဖို့များတယ်ချင်းသေးတော့မဟုတ်နဲ့တူတယ် So if there is no more comments or questions, so let's give a great applause to Xiao Mumie for his daring operation, saving 2 lives. Thank you, Kobo. So
okay, thank you so much. Yeah.
So we would like to proceed with a third case, which will be presented by Dr. Winko Kutet from North Oklahoma Teaching Hospital. So he's going to present a synchronous primary tumor. Dr. Winko Kutet, please.
Thank you, Xiai. Thank you, Xiai, for your kind introduction. And good afternoon, Xiai, and for all my senior and junior colleagues. My topic is synchronous primary tumor. This is my introduction. For the cancer of colon and kidney are common malignancy. The incidence of coexistent colon cancer and renal primary tumor are rare. The incidence of synchronous renal cell carcinoma and colorectal cancer is heterogeneous, ranging from 0.03 to 4.85%. The etiology and pathogenesis of such multiple tumor remain unclear, although some hypotheses that concurrent tumor can rise from the tissue of same embryological origin. Coexisting tumor in the colon and kidney are more often diagnosed downstream due to the widespread use of ultrasound, CT scan, and MRI technique. In this report, I will discuss about the synchronous primary malignancy or colon cancer in 75-year-old lady and 53-year-old gentleman. They have the different story. In the case one, first of all, I would like to tell that this case has been previously present in the Myanmar Journal of Surgery. This is the case one. A 75-year-old lady present with a history of a small amount of liver written often for 3 months duration. So we did colonoscopy and wished to carcinoma of the proximal descending colon and biopsy will be moderately differentiated adenocarcinoma. We did staging workup with CECD abdomen and pelvic, which will be incidental finding of the renal carcinoma 2.3 into 2.7 centimeter at the side of mid region of the right kidney, located laterally, and the carcinoma of the proximal descending colon, which is asymmetric thickening of the coronal wall about 6.6 centimeter. And so we did CA, which is not raised. This is the CT scan which show the carcinoma, renal cell carcinoma at the mid portion of the right kidney. And this is the CT scan of the carcinoma of the descending colon. So we discussed the many option with the management option with the oncologist and neurosurgical team. Decision was made for this surgery with the straight incision for the individual malignancy. So we planned for the left hemicolectomy for C colon and the Y local incision for the RCC. Left hemicolectomy was approached by the midline incision by the colorectal team and operated by anywhere and accelerated through at the proximal descending colon with zero state involvement and intermediate no enlargements, no liver secondary, no ascites, and no peritoneus. Neurosurgical needed the Y local incision of the renal carcinoma by the right supraarterial incision and through at the metabolism of the right kidney is fitted 2.5 to 3 centimeter, no involvement of the peritoneal system, and no renal enlargement. Our post-operative course was uneven and she was discharged on 10 post-operative. Our biopsy revealed the renal carcinoma, clear set type right kidney, tumor was close to the one proximal, one recession margin and myoglomerulosclerosis of the underlying kidney. Colonic biopsy revealed the ulcerative poorly differentiated adenocarcinoma GP. All the recession margin, including the CRM, were free from tumor. Reactive follicular and sinus hyperplasia was loaded in one lymph. This is the biopsy specimen, which shows the renal cell carcinoma in the upper figure, and this is the poorly differentiated adenocarcinoma of the colon. So we did adjuvant therapy with oxaliplatin and capecitabine behind the medical oncologist. Now the patient has 3-year post-operative period, and she is on regular checkup with imaging, tumor marker, and colonoscopy. She is well without any tumor burden up to now. This is the heavy story, and the case 2 will not have the heavy story like this one. Case 2 in there. These 8-year-old gentleman with the chief complaints of liver written often over 5 months duration and history of constipation, change in bowel habit, early morning fluid diarrhea, which is more troublesome for him, and the sense of incomplete defecation are present. No history of hematuria nor other urinary symptoms. On abdominal examination and remarkable and digital rectal examination are surgical at the 8 centimeter. Colonoscopy we did and finding where nodular ulcerated lesion on the whole circumference of the rectum starting from 8 centimeter up to the 15 centimeter, which is down segment. Biopsy will be moderately differentiated adenocarcinoma. So we do the staging workout, CT abdomen and pelvic, CT C return with mesorectal fat invasion and regional mesorectal lymphadenopathy. Circumference was again up to 7.3 centimeter at the mid of the rectum. Synchronous left RCC. A bit enhancing match at the 6.56 into 7.4 centimeter at the mid and lower border of the left kidney. Left renal vein and IVCs are fitted. This is the CT scan of this patient, and apologize for the poor quality image. And this is the venous cell carcinoma. This is the down segment tumor at the reducible retin. So we discussed the management option at the monthly GI and hepatobiliary imaging with the oncologist, radiologist, pathologist, and then we discussed also with the neurosurgical team, and the decision was made for the palliative surgery. So we decided, we planned for the one-stage surgery for both malignancies because they are on the same side. So we did a left vertical nephrectomy and palliative low ARR and cover ileostomy was done by the surgical team. And operated finding were the left venous cell carcinoma would grow about 6 into 4 centimeter and lower 1/3 of the carcinoma of the retina, which is called probably 7 centimeter in length, involving the 3/4 circumference of the retina, but no ascites, no liver secondary. This is his biopsy result, colonoscopic biopsy result, show the invasive moderately differentiated colonnade biopsy result show the invasive moderately differentiated adenocarcinoma of the retina invading up to the muscular propria surface, which is T3. Lymphovascular invasion are not present. All recession margin, including circumferential recession margin, are free from tumor. And metastatic lymph node present in the 5 paracollar lymph node. Distal renal vein is free from the tumor. This is the renal biopsy, which reveals the clear cell renal cell carcinoma invading the perinephric and renal pelvic. Tumor size was 6 centimeter. Recession margin was free from tumor. His post-operative periods were uneven proven. He was discharged from 12 post-operative days. Although he has aggressive tumor, he can only do the 4 cycle of chemotherapy and stop due to the severe response to chemotherapy because of severe anemia, which cannot be revived by the GM-CSF, and he received only 10 fraction of the radiation therapy. At the 7 months post-operative time, the patient came back to the hospital with chief complaints of pain and left iliac fossa and left flank pain. And on the examination, the patient condition was pain, the fila was present, abdomen is soft and mass in the paraumbilical region and left flank. So we did CD abdominal baby, which showed less recurrent tumor mass involving the retina, secondary colon, left sewer mass in patient, and liver secondary. So we plan for the palliative care after consultation with oncologists. The patient condition generally worsened and is covered at 7-9 post-operative. This is my discussion. The presence of concomitant synchronous malignancy was first described by Warren and Kay, who was stated that each tumor must be present with definite picture of malignancy. It must have a distant pathological proven possibility of 1B metastasis or other must be excluded. In case 1, coexistence of 2 primary individual tumor, one in the semicolon, one in right kidney. In case 2, one in lower retina and one in the left kidney. In both cases, RCC is asymptomatic and incidental finding on CT scan. So the concomitant of RCC with other primary has been described, such as the C bladder, C prostate, colorectal, lens, C lens, and black malignant melanoma of the skin and non-Hodgkin lymphoma. A recent report described that 4.8% of synchronous primary, synchronous colorectal and renal carcinoma. But in the previous literature, which is 0.03 to 0.5. Renal carcinoma may be translated into association with second primary tumor and elderly cancer patient. It has been found that asymptomatic and clinically identifiable kidney cancer can be common finding in the elderly patient with multiple malignancies. Synchronous colon primary renal tumor described in the Lynch syndrome, which describes the HNPCC and neoplasm of other organs like endometrium, ovary, breast, kidney, and other. And 70% of HNP mutation or the full measurement mortality can be found. In our case, it is excluded because there is no history, no strong history of family history. However, in the literature, some of the synchronous colon and renal carcinoma did not have family history of malignancy. Silent growing RCC often diagnosed during the stage of the other primary malignancy. In the study of the lead, about 2.6% of the patient with colorectal cancer synchronous tumor and have primary tumor. Curative research is still a valid option for these patients. Two regional research in preferable and extended research on about simultaneous surgery for the synchronous disease or different organ, which has several advantages like a longer operation time, more blood loss, and higher cardiopulmonary risk. This is my conclusion. The coexistence of both colon cancer and primary renal cell carcinoma outcome more in elderly. Popular use of imaging such as CT, MRI, PET scan may be related to high probability of multiple primary malignancy. Curative research is still possible for home malignancy, but thorough stage and evaluation with multidisciplinary is mandatory. These are my reference and the take-home message. In the management of the malignancy, it is important to perform routine periodic check that to exclude other synchronous primary malignancy. In the workup of malignant tumor, primary tumor can be detected, and curative treatment should be aimed in the presence of multiple malignancy, even in the presence of multiple. These are the references. Thank you, CIE.
Thank you, Dr. Wimbu, for your interesting presentation. There is a comment from Sai Union Day. So, Sai Union Day question: is it really a two primary tumor? Because it could also be secondary in kidney with primary in the colon or rectum. So, Sai, clear cell RCC resembles mucinous adenocarcinoma in histology. The special stain in Varimia. Look at the la, era live PB Java.
So biopsy result got clear cell carcinoma, clear cell carcinoma or RCC, poorly differentiated adenocarcinoma first year, poorly differentiated adenocarcinoma. Oh, say embryology.
Special stain of the la, sir.
Special stain of look about pathologist recommend.
Yeah, တခုလောက်ပြောလို့ရ
Yeah, please.
ဟုတ်တယ်နော်ဆရာဦးညွန့်တယ်ကျွန်တော်ငယ်ဆရာပါဆရာကြီးကအဲ့ဟို clear cell မှာကျွန်တော် HNE stain ဆိုတော့ glycogen တော့ပါရရှိတယ်အဲ့ဒါဆိုရင်သူက cytoplasm clear ဖြစ်တယ် fat ဆိုလည်းအဲ့တိုင်းပဲတွေ့ရအဲ့ကြတော့ကျွန်တော် special stain ပေါ့ fat ဆိုရင် oramin o လူစင်တော့ဘာနဲ့လုပ်လဲမသိဘူးဟိုဒီမှာတော့ကျွန်တော် signal ring cell ကိုပြောတယ် signal ring ဆိုတော့ nucleus တစ်ဖက်ကို push လုပ်တယ်ဟိုဟာဆိုတော့ center မှာရှိတယ်ဟိုစောစောကျွန်တော် slide ကြည့်ရတာဆရာဦးညွန့်သိပြောခဲ့တာကျွန်တော်အမှတ်ရတယ်ဆရာဝင်းကိုတဲ့ပြန်ပြလိုက်ပထမ first case slide တယ်ရှိတယ်ဆရာကြီးကြည့်လို့ရတယ်ဆရာကြီးညွတ်သိတစ်ချက်ကြည့်လို့ရတယ် center မှာတင်တယ် nucleus center မှာလို့ယူဆတယ်တော့ငယ်ငယ်ရလေဆရာကြီးညွတ်သိတို့ဆရာမကြီးတို့ဟိုဒေါ်ထားကြည့်လို့ပြောခဲ့တာ we all swim in the sea of gassing ဟိုဒါတမဆရာကြီးတစ်ချက်ကြည့်လို့ရတယ်ဆရာကြီးညွတ်သိပေါ့ nucleus center ကျွန်တော်အမှတ်သိတော့မကြည့်တာဘူးဒါပေမဲ့အလဲ slide upper 3ဟိုထဲမှာဆရာကြီးတစ်ချက်ကြည့်လိုက်ဆရာကြီးမှန်းလို့ရဒါပေမဲ့ဟုတ်ပါဆရာကြီးပြောဆို special stain လောက်ရမယ်ပေါ့လေ special stain လောက်ရမယ်အဲ့ကြမှာကျွန်တော်ကဒီ mucin လား secondary သွားလာအဲ့ဒါကြည့်ပါဒါပေမဲ့ signal ring center တော့မတူဘူးတင်တယ် centrally nucleus are centrally placed တော့ဒါပေမဲ့ဆရာကြီးတို့ pathologist ပို့တည်ရတယ်ဆရာကြီး comment ပေးလို့ရတယ်ဆရာကြီးပြောသလိုလိုတာပေါ့တဲ့တကယ်တော့အဲ့လိုလုပ်တယ်
ဒီမှာဒေါ်သီတာအောင်ကလည်း if you have to do separate operation and not simultaneously which one do you perform first ဒီချိန်နဲ့မလုပ်ဘူးဆိုရင်ဘယ်အောင်အရင်လုပ်ပါမလဲတဲ့အချိန်ကတော့ကျွန်တော်တို့က9မိနစ်လောက်တော့ကြံသေးတယ်ဆိုတော့
ကျွန်တော်ကိုလိုစီကံအောင်စီ return အောင်ရင်လောက်ပါမယ်ဘာဖြစ်လို့လဲဆိုတော့ obstruction နဲ့ patient အရင်သူ့ရဲ့ troublesome ဖြစ်တာ first case first right
and Professor Uttamalingale, thanks for a nice presentation. How about consideration of laparoscopic partial nephrectomy? nephrectomy in case 1, either transperitoneal or retroperitoneal approach to avoid 2 big incisions in 1 case.
အဲ့တော့ Urosurgical team ကိုကျွန်တော်တို့ပြောပါအဲ့တော့ Urosurgical team ကိုကျွန်တော်တို့ decision အတွက် discuss လုပ်ပြပါသူတို့ကတော့တစ်ဖက်ထဲမှာလည်းဖြစ်နေကျွန်တော်တို့ကိုလုံးဖယ်ပြီးတော့တဲ့အချိန်မှာကျတော့ကင်ဒီကတန်းပေါ်လာတယ်လို့ဖယ်တိုင်းမျိုး radical ဟောတယ် first case ကတော့စီးတဲ့တက်စီဖြစ်နေတဲ့သူ separate ဖြစ်နေတယ်
Yeah, I for like the question. Some more by sugar. Okay. Any more comments or questions from the audience? Please go.
ဟုတ်ကျွန်တော်ဟိုတော့ရန်ကုန်မှာရှိတော့ဆရာကြီးဥထုံးကဟို adrenal tumor တွေကျွန်တော်ခွဲပြီးတော့ဆရာကြီး case တင်တော့အဲ့ဒါဆရာကြီးဝင်းမြန်ထမယ်ဆရာကြီးဘာကြောင့်ရှေ့ကခွဲတာပေါ့နောက်က approach မလုပ်လို့ဆရာကြီးဥထုံးကဆရာကြီးပြောတဲ့စကားကျွန်တော်မှတ်ပြီဆရာကြီးကတကယ်တော့ဟိုဖြစ်တာဟုတ်တယ်ကျွန်တော် general surgeon ကရှေ့က anatomy ပဲပိုကျွမ်းတယ်ပေါ့ဆရာကြီးဝင်းမြန်တော့ euro တွေအကုန်တော့ posterior လုပ်တယ်ကျွန်တော်ကျောင်းသားဘွားတော့ဟို IVC တော့ aorta တော့ approach ရှေ့ဘက်ကပို့ပြီးတော့ကောင်းတယ်တကယ်တမ်းကြာကျွန်တော်ဆရာကြီးတွေစာသင်ရတဲ့အချိန်ကြတယ်သူတို့ posterior ပို family ရဖြစ်တော့ဘာကြောင့်မှန်းတော့မသိဘူးအဲ့လိုပေါ့အစတော့သူတို့ control တွေပါတောင်ပြောသေးတယ်ဒါပေမဲ့အဲ့ဒါပေါ့ဒါပေမဲ့ဟို second case ကတော့ဟုတ်တယ်ကျွန်တော် principal နဲ့ကြိုက်တယ် laparoscope တော့ကျွန်တော်သိနားမလိုက်ပေါ့ right case ကတော့ left hemi လောက်ပဲပြီးတော့မှ right colon ကြီးကိုလှန်အောင်မယ်ဆိုတော့အဲ့ဒါကြောင့်သူတို့ left လောက်လာတော့မသိနောက်တစ်ခုက contamination ပေါ့ colonic contamination ဆိုတာအဲ့ဒါပေါ့နောက်တစ်ခုကတော့ဟုတ်တယ်ပေါ့ဟိုကျွန်တော် general surgeon ကရှေ့ကနေလို့ euro surgeon ကဆရာကြီးတွေတော့ပါတယ်ဒါပေမဲ့အချိန်တိုင်း limit ဆိုတာမသိဘူးဘာကြောင့်လဲဒါပေမဲ့သူတို့ကအများအားနောက်ကလောက်တယ် tumor principal ကတော့ရှေ့ကပို့ပြီးတော့ကောင်းမယ်ထင်တယ်အဲ့လိုကျွန်တော်ကြားဘူးတာဗျဟုတ်ကဲ့ thank you ပါဆရာအချိန်ပေးတယ်
ကျွန်တော်တို့ကျွမ်းကျင်ရလိမ့်မှာပေါ့ဗျာကျွန်တော်တို့ကိုတက်တဲ့ဟာပဲကိုလုပ်တာပေါ့ဆိုကျွန်တော်လည်း focus လုပ်လို့ရှိရင်ဘာဖြစ်လို့ဒီလိုပဲဆက်လဲဆိုကျွန်တော်ဒီတစ်ခုပဲတက်လို့ဒီတစ်ခုပဲဆက်ပါတယ်လို့ပဲကျွန်တော်ဖြေပါတယ်ကျွန်တော်So only 2 minutes left. So if there is no more question or comments, I would like to conclude the sections. So ဒီနေ့အဖို့ကတော့ကျွန်တော်တွေ့ရတာတော့ကြာသာပတိနန်ဆေးုံကြီးနှစ်ခုကနေပြီးတော့ကြာသာပတိသားသမီး2ယောက်ရဲ့ case တွေပေါ့လေအကုန်လုံးတင်လာတဲ့အတွက်ကြောင့်ကျွန်တော်ကကြာသာပတိအဖွဲ့ကိုအကုန်လုံးကျွန်တော်တို့ကျေးဇူးတင်ပါတယ်ဒီမှာသူတို့က although they are doing a heroic surgery they are not doing it ဟလာဟိုဗျာမရာလောက်တာမဟုတ်ဘူးပေါ့ကျွန်တော်တို့အကုန်လုံးကျန်တဲ့ junior တွေပါလမ်းလို့စီနေတာကတော့ before they are doing these complicated dealing with complicated cases they consult with specialists accordingly and they put up the case in the meeting or something like that and they made a joint decision ဆိုတော့အဲ့ဒါလေးอ่ะပေါ့ကျွန်တော်တကယ်ချင်းတယောက်ပြောသလိုပေါ့ဟုတ်လားဟိုတော့ဆိုရင်တွေ့ဟာငါလှုပ်လိုက်မယ်ဆိုတာမျိုးလို့အခုခေတ်ကကြတော့အခက်ခဲတွေ့ပြီဆိုလို့ရှိရင် call for help နော်ပြီးတော့အကူအညီတောင်းဖို့ဝင်မလေးဖို့ဆိုတာလေးတွေကကျွန်တော်တို့ခေါင်းထဲမှာနောက်လာမဲ့လူလောက်ကြမဲ့လူတွေခေါင်းထဲမှာလည်းရှိထားဖို့အရင်အရေးကြီးပါတယ်နော်ဟုတ်လားကျွန်တော်တို့လိုအပ်ရင်လိုအပ်တဲ့အချိန်မှာအကူအညီတောင်းလိုက်ပါအခုချိန်မှာအရင်လွယ်ပါတယ်တယ်လီဖုန်းနဲ့ပဲစစ်ပြီးတော့တောင်းပါဘာလို့ပါဒါကလူ့မှာအောက်ကျရတာမဟုတ်ဘူး to save the patient life ပဲဆရာဦးမိုးမြင့်ပြောသွားသလို above all do no harm ဒါလိုလောက်လာလဲဒါဒီ principle လိုက်တာပဲ we didn't do any harm by just consulting with each other ဟလာခု tele consultation နဲ့သိလွယ်တယ်ဆိုတော့အဲ့ဒါလေးကိုကျွန်တော်ပြောရင်းနဲ့ကျွန်တော်တို့ဒီနေ့ surgical clinical section ကိုညီကုန်းချုပ်ချင်ပါတယ်ခင်ဗျာအားလုံးကျေးဇူးတင်ပါတယ်
ကျေးဇူး